Thank you for inviting me to speak today. It's a it's a pleasure to meet all of you today and kind of show what we're doing here as a team at UCSF and also in radiation oncology. So usually I begin my presentations with a case, that I've treated in the past, and it's just to bring us, I guess, to something that we can be familiar with. So my patient was a 65-year-old female who presented with perianal pain, lower GI bleeding, and was anemic, had bleeding resulting in a hemoglobin of 7. So when she came in on exam, we saw that she had a large 6-centimeter mass protruding through the anus and a bulky right inguinal lymph node. So our next question when we see our patients is, how do we manage our patients? So just to give you an overview of what I'm going to briefly speak about today, I'm going to go over the anatomy of the anal canal, the treatment, side effects, and how we have strived to improve some of these side effects in treatment. So the anal canal is about 3 to 4 centimeters in length, and it usually starts from the non-hair bearing skin. That's what we call the anal, the initiation of the anal canal, and it's about 4 centimeters. On exam, we can feel it as a ring, kind of, and that's where it usually ends. So patients usually present with rectal bleeding, pain, or some of the patients have serial screening, which Dr. Berry will talk to you about for pre-malignant lesions, and we'll find anal cancer in them. At initial presentation, most patients have early disease, small tumors, less than 2 to 5 centimeters. About a third present with positive lymph nodes, and less than 10% have metastatic disease. So the initial workup for our patients include a detailed history and physical exam. And we usually have our patients undergo an endoscopy proctoscopy, which Dr. Berry will talk to you later about, and routine labs including a complete CBC with differential and HIV screening. Also, in all our patients, we get a PET CT scan, and talked about imaging as my area of research interest. PET CT is very, very sensitive for detecting sites of disease, especially distant metastatic disease and nodal disease. That's why we get it. It's about 90% sensitive. So here is the same patient that I initially presented. You can see this is looking at a pelvis view, and this is the area that's very bright on the PET scan, telling us that this tumor is active. And also in the right groin area, you can see a lymph node that's also showing up. That's why these scans are very useful. So talking about the old days, well, I like to give some history in my talks. So back prior to the 80s, talk about advances back before the 80s, the standard of care was to do a pretty big surgery where they would remove the anus, the rectum, and all the lymph nodes. It was a pretty morbid procedure, and it resulted in a permanent colostomy. But in terms of recurrence rates, still about a third of the patients were recurring. So this guy, Norman Nigro, actually back, I think in the 80s, early 80s, started, how can we improve the outcomes of surgery? Why don't we add chemoradiation treatment? So at that time, they added chemotherapy, what we use now, 5-FU and mitomycin C, and a low dose of radiation. And all these patients went to surgery, but at the time of surgery, about 84% of these patients had no evidence of disease. So it showed us that chemoradiation really worked to eradicate the disease. So here's there's survival. A lot of the people that had no evidence of disease after chemoradiation, there was about a 90% survival rate. So they, at that time, stated that that should be the standard of care, just definitive chemoradiation, omitting the surgery. So that's how there was other subsequent large studies that validated these findings, and it became our standard of care, what we use today in the clinic. We give chemotherapy twice during week 1 and week 4 with 5-fluorouracil and mitomycin C, and also we give 5.5 weeks of radiation therapy, anywhere from 28 up to 30 treatments. So looking at characteristic factors to help, I guess, prognosticate the outcome, there were several studies that were done. In general, they saw that females had a higher risk of recurrence. Tumors that were greater than 5, actually males have a higher risk of recurrence, sorry. Tumors greater than 5 centimeters also were likely to recur. And then we see about 30% recurrence in patients that have tumors greater than 5 centimeters. This is across the board for multiple clinical trials. And also having positive lymph nodes was a bad prognostic factor. Going into the toxicity, that's what we're here to talk about. With chemoradiation therapy, you can see during the treatment, there was a high toxicity rate, 60% grade 3 to 4. These are pretty significant toxicities, medically significant grade 3, requiring hospitalization, or grade 4, life-threatening complication requiring urgent intervention. And a lot of these toxicities were skin toxicity, GI toxicity like diarrhea, significant pain, or drop in blood counts, 25% to hospitalizations and 5% that were life-threatening historically. So as I mentioned, the standard of care was 5-FU mitomycin C. So there was a trial that was done in the UK looking at how can we decrease the toxicity, especially the blood toxicity, the drop in counts during the radiation treatment. So they looked at substituting the mitomycin C that I was talking about during weeks 1 and week 4 with cisplatin. So this trial compared 5-FU mitomycin C with 5-FU cisplatin. And they saw very, very similar outcomes in terms of controlling the primary tumor or controlling metastatic disease. However, what they saw was a significant improvement overall with decreasing the hematologic toxicity, the drop in blood counts. And this is pretty important. Also, how else can we improve? Our radiation techniques over the past 20 years have significantly improved. Historically, we would give these big, wide open fields that would, treat everything that it encompasses, the bladder, the pelvic bones, which can also cause a drop in your counts, the anus, the rectum, and such. So now, now we can use intensity modulated radiation treatment. This is what I routinely use in the clinic. And we can scope out the doses to the areas of involvement that we see. Here was the anal tumor, and here was the lymph node that you saw in the PET scan. And we could really scope out the dose. The red is our prescription dose, our hot dose. And here is our elective. We have to treat elective lymph nodes that are at high risk. But you can see that we're able to spare a lot of bone, the remainder of the skin and such. So using IMRT, there was a large clinical trial that was run through the radiation therapy oncology group, which we participated in here at UCSF. And there was a significant improvement in toxicity, GI toxicity, skin toxicity, and what isn't shown here is now the data is coming out for improvements, long-term improvements in sexual, sexual dysfunction, and you see improvements in sexual dysfunction of intensity modulated radiation therapy. Last thing, I mentioned earlier on about the prognostic factors. Remember, I mentioned that tumors greater than 5 centimeters were more likely to I guess, recur locally. So here at UCSF, we're working on developing a technique where we can even give higher doses of radiation to these large tumors, just locally into those areas while minimizing the dose to the other surrounding normal structures. And in that way, we can reduce toxicity and make our treatments more applicable. So I always like to end my talks with a happy ending, and here's my happy ending. You remember this scan, pre-treatment, afterward, you see no evidence of disease. Here was the same patient, pre-treatment, really big tumor, and post-treatment, it's all gone. Yeah. So how do I follow up my patients? I do routine physical exams, and I do a digital rectal exam at each physical exam. Usually 6 weeks out, I see my patients, and every 3 months thereafter. If the patients, one of the things I didn't mention is the patients have a lot of skin toxicity during the treatment. The skin breaks down in the groin and the perianal area, and we like to see our patients daily, even weekly, and after the treatment to follow up and manage. We have a great nurse who's sitting right back there that helps a lot with our skin care. She's great, Ludine. Yeah. And we on the exam, if there's any question of persistent disease, we follow it. And this is one thing that's really important, because 3 months out, 6 months out, the tumors will continue to respond. Yeah, you know, even after a year. You only biopsy if the tumors start growing. And Dr. Barry will talk to you later. He helps me out a lot with doing the anoscopies as part of the surveillance. Yeah, thanks a lot.